150 peer-reviewed publications, his work has significantly advanced kidney transplantation in India, particularly in the areas of deceased donor programs and kidney pair donation. He is treasurer of the Indian Society of Organ Transplantation, former secretary of the Indian Society of Organ Transplantation, treasurer of the Transplantation Society, counselor of the Asian Society of Transplantation, and member of the Apex Technical Committees at Noto Robusto. He is also ranked #1 expert in kidney transplantation in India as per the experts team. We welcome you, sir, to give your presentation.
Thank you, madam, for the kind introduction. And I have no words to express my gratitude to Dr. Anil Kumar, sir, and Noto family for giving me this opportunity to interact with you on One Nation, One Swab Transplant program for achieving self-sufficiency, challenges and solution. As per GODT registry, less than 10% of patients with end-stage organ failure have access to the organ transplantation. With the leadership of Noto, India is number 3 in the world for absolute number of organ transplantation and number 1 in the world for living donor organ transplantation. 85% transplants in India are from living donation and around 15% are from deceased donation, which is active mainly in the South and West India. Over the last 10 to 15 years, the deceased donation rate per million population in India is less than 1. And to achieve self-sufficiency with deceased donation, the required rate is 64 per million population, because the estimated need for kidney transplant is around 1.5 to 2 lakhs. So India is number 1 for living donor transplant and number 68 for deceased donor organ transplantation. These two modalities complement each other to increase access to the organ transplantation. 1/3 of the living donors, they are rejected because of either ABO or HLA incompatibility. These donors can be easily transplanted with swab transplant or ABO incompatible transplant. Around 80% of kidney transplant services in India are in private sector, where cost is prohibitive for a common man, and cost of ABO incompatible transplant is twice as expensive as compared to the ABO compatible transplant, with added complications because of infections. So this is our largest registry of ABO incompatible transplant from 25 centers, and 1759 ABO incompatible transplants were compared with 33,000 ABO compatible transplants. The main problem were cost and infections. So the legal and cost-effective solution for incompatible patient in Indian scenario is a swab transplant, where two incompatible pair exchange kidney with each other to receive the compatible ABO compatible transplant. This is our single center experience of kidney swab transplant. Data from 2000 to 2024, 539 kidney swab transplants were included in this single center analysis, and this is the largest single center study published in the Asia. Graft survival, patient survival, acute rejection rate, graft function is similar to any ABO compatible transplant. And if our success is replicated in other centers in India, this will increase living donor kidney transplant by 25%. In our center, so far, we have done more than 600 kidney swab transplants. 75% are two-way exchange. But to increase access to difficult to match patients, we have also done a long cycle like 3-way, 4-way, 5-way, 6-way, 7-way, and even 10-way cycles, that is 10 patients and 10 donors were transplanted with the swab transplant. Basically, more surgical team is needed to carry out simultaneous surgery in the long cycle. This is our recent publication in prestigious Lancet Asia journal, nationwide retrospective cohort study, 2 decades of kidney and liver swab transplant in India. 1839 kidney swab from 65 centers and 259 liver swab from 7 centers were included in this retrospective analysis. Around 90% of kidney and liver swabs are two-way exchange. Due to lack of software, we usually perform the two-way exchange, and more surgical team is needed to carry out simultaneous surgery if we perform long cycle like two-way, three-way, and long cycles. So lack of software and surgical team limitations are the reasons for performing short cycles in India. This is the largest registry of kidney and liver swab published in the world literature from 72 centers. It concludes that swab transplants are medically simple but logistically complex. Access to kidney and liver swab was unequally distributed and likely underused in our cohort. The left panel is showing India map of living donor kidney transplant, and right panel is showing India map of living donor kidney transplant with swab. Gujarat is number 1 state in India performing maximum number of swab transplant. Like in our single center, we have performed more than 600 swab transplants. Then Maharashtra, Rajasthan, Delhi, and Kerala. These are the top 5 states for swab kidney transplant in India. So what is need of one nation, one swab transplant program? Our single center experience has shown that living donor kidney transplant can be increased by 25% despite a single center program. If we start the national program or multi-center program, this will increase living donor kidney transplant by 25 to 35%. So, for example, around 12,000 living donor kidney transplants are performed in India with the help of national swab transplant. Additional 3,000 to 3,500 swab transplants will be generated. So, when these patients will be also reduced from the deceased donor waiting list, that is another major advantage of national swab transplant program. Then less surgical team is needed for simultaneous surgery to avoid donor renage. That is one of the biggest advantage of multi-center program and national swab transplant program. So based on our experience and publication in Lancet Asia, I will briefly discuss challenges and solution for national swab transplant program under the headings of legal permission, registration, allocation, undertaking multicentric swab, and addressing the patient's concern. Legal permission for multicentric swab. It is legally permissible under Organ Act provided that it receives necessary approval from authorization committee, follows ethical practice, and ensure informed consent from both donor and recipient. It should be explicitly addressed so as to avoid any hesitancy and different interpretation of the act in relation to the swab. Which donor recipient relationship is permissible in swab? Currently, only near relatives, that is parents, spouse, sibling, grandparents, as defined under Organ Act, are legally permitted to participate in swab transplant. The act may need to be relooked and modified, not to restrict only to near relatives in swab, to optimize matching like in any other living donor kidney transplant. This is done in the state of Kerala. Then is interstate matching is permissible? Yes, our Lancet Asia paper shows that almost 50% pairs are from interstate matching. So interstate swap is legally permissible under THOA and should be encouraged to expand matching opportunity. It should be explicitly permitted under Organ Act, and broader guidelines should be included under rules. Then who should give permission for multicentric swab? On page number 42 of Transplant Human Organ Act 2014, it is mentioned that authorization committee of hospital or district or state in which transplantation is proposed to be done should give permission for multicentric swab. This approach ensures consistency, transparency, proper oversight, while ensuring compliance with the Organ Act. Documents required for the multicentric swab. I would like to acknowledge the uh, letter from Dr. Anil Kumar sir about the checklist required for the swab transplant as per the Organ Act, and before accepting any confirmatory match offer for payers, all center must ensure that documents in accordance with the NOTO checklist under Organ Act are completed, checked and uploaded. Legal process may be expedited with online document submission, Aadhaar enabled biometric clearance system and video interview of the pairs. The authorization process should be completed within 7 days and any delay must be explained as per suggested by the DGHS letter. Where the payer should register for the swab transplant. A centralized national online swab registry portal by NOTO should be established where all payers are mandatorily registered and information and data can be assessed as per legal and eligibility framework. What should be the ideal timing of swab counseling with the payers? Swab should be introduced at first counseling session for eligible payers, ensuring that all patients registering for deceased donor kidney transplant are offered counseling about all available alternatives of renal replacement therapy, including swab transplantation. We have noticed that 90% of the patients who are registered on the deceased donor waiting list, they are not available. They are not aware about the alternative options. Many times they have incompatible donor, but they are not explained about this option. So I will request Anil Kumar sir that a letter may be issued mentioning that awareness about all options of renal replacement therapy, including swab transplant, should be made mandatory for all patients who is getting registered for deceased donor kidney transplantation, so that patient can take informed decision considering into account pros and cons of available options as per the resource settings. Then donor participation in the swab. Donor must be medically fit, mentally competent, free of pressure and financial gain, and undergo psychological evaluation. Clear documentation and joint case review between centers are crucial for ensuring transparency and safety. Then whether complex living kidney donor can participate in swab. This is very common because we have limited donor pool. Many times the parents and spouse are having hypertension. They are on single drugs and comorbid condition is well controlled. So recipient willing to accept complex living kidney donor should be clearly documented and recorded in the swab registry to ensure transparency and support informed decision making. As far as possible, organ of similar quality should be exchanged. That is, complex living kidney donor can be matched with complex living kidney donor to maintain fairness and clinical balance within the program. Then, can multiple donor do registration for one recipient? Yes. Multiple healthy willing donor may be registered specially for difficult to match pairs, but will be linked with the same recipient to improve the matching chances and reduce the waiting time. Final donor selection should be based on clinical and immunological suitability once a match is identified. Then donor recipient HLA and age mismatch pair, that is compatible pair enrollment. Inclusion of such pair in swap, if done, must be voluntary and fully informed consent must be obtained. Payers must understand that participation may not guarantee access to a better donor because this depends on the donor pool. Any benefit conferred to such pair must be transparently documented, that is, improve HLA match, young donor age, or lower risk profile as per living donor KDPI calculator, and justifiable based on medical need or program utility. Their participation must be time bound and a clear timeline should be discussed at registration to ensure unnecessary delay in the transplant. Variation in donor and recipient fitness criteria in different centers. All centers participating in multicentric swap should adhere to uniform evidence-based eligibility criteria for assessing donor and recipient fitness. Transparent documentation and joint review mechanism should be established for complex or borderline cases to ensure consistency and clinical accountability. Frequency of donor and recipient fitness assessment after registration. Fitness for both donor and recipient should be regularly assessed. Updated transplant team clearance with designated time frame must be obtained before accepting the final allocation matching offer for swap pair and prior to seeking legal approval for transplant under Organ Act. Then immunological workup. We suggest a robust immunological evaluation to prevent unequal outcome because of immune injury. It should include ABO typing, HLA typing of both donor and recipient, preferably high resolution, and HLA antibody detection in sensitized patients using standardized method at accredited labs. All test results must be digitally recorded and standardized across participating center, available to the central registry for real-time match run simulation and accompanied by declaration of unacceptable antigen in sensitized patients. So robust immunological assessment prevent unequal outcome because of immune injury. Then enrollment of the pair. We recommend that NOTO establish one window clearance system for registration, allocation, and facilitating legal permission even though health is a state matter. Because swap transplant is basically logistically complex. No extra services are required other than any living donor kidney transplant program. Then information to be documented at registration. All medical details of recipient and donor transplant center should be entered in a centralized online database of NOTO. All legal documents and medical reports must be submitted and informed consent for data sharing should be taken from both donor and recipients to ensure smooth coordination between centers. Then how long pair should wait for getting swab transplant? A large swab pool minimize time required for getting the pair in the swab. So expected waiting time should be clearly communicated at swab registration and pair should regularly updated. Additionally, yearly counseling should be provided to explain all available options, including ABO incompatible transplant and desensitization protocol, so that all modalities can be complemented to increase access to the kidney transplantation to individual patient as per available resources. Pair matching in multicentric swap. A centralized, standardized swap matching platform should be adapted, accessible to all authorized center and integrated with registry. Access to swap should not be denied in absence of single window registration allocation, particularly in the resource limited setting. So far in our center, we have used a software provided by Alliance for Pair Donation, but recently Indian Society of Organ Transplantation has also made the software which we have demonstrated to the NOTO so that a best possible way can be find out for starting the most user-friendly software in the national program. Optimal frequency of match run. It should be 4 to 6 weeks. Balancing clinical urgency, logistical capacity, and registry size. There should be flexibility to allow ad hoc run in exceptional cases or special requests from the payers, particularly for sensitized and urgent recipients. What is acceptable match pair? An acceptable match pair should be identified through a validated matching process in which donors meet recipients' medical, immunological, logistical criteria, and both transplant center confirm clinical suitability and willingness to proceed. Uniform definition of accepted match pair should be adopted in the national program. Then what is the importance of donor recipient age mismatch? Donor recipient age mismatch should be minimized when possible, particularly for the young recipients, to maximize graft survival and long-term benefit. While not an exclusion criteria, age difference more than 20 years should trigger additional clinical review and shared decision making between transplant team and patients. However, it should not be limiting factor for hard to match patients because donor age between 18 to 65 year does not matter for outcome of living donor kidney transplant. Then what is impact of donor age difference? Efforts should be made to match donor age of each pair as closely as possible. For hard to match pairs, pair with longer waiting time, donor age matching should not be given much importance and pair should be counseled accordingly at the time of registration because we also need to consider morbidity and mortality on long-term dialysis program. Then non-immunological donor characteristics, transparent sharing of relevant non-immunological donor information through counseling of peers should be ensured to support informed decision making and maintain trust between peers. Then which should be promoted? Multi-center or single-center swab. National and regional transplant authorities should actively support and prioritize development and governance of multi-center and national swab over single-center program because the quality and quantity of matching will be better in the national program. This include establishing interoperable registry, standardizing clinical protocol, investing in match algorithm, data infrastructure, coordination mechanism to ensure equitable access and maximize transplant opportunity. Then what should be the way forward from single center to the national program? It should be started in a phased manner, starting from city, state, multi-state, and national program. This approach balance scale with operational readiness and ensure safe, equitable, and efficient transplant delivery across geography. Then what should be preferred? Short cycle versus long cycle in the multi-center swab. Initially, limit exchange to the two-way and three-way cycle because logistics are very simple in the short cycle. Long cycles may be considered for hard to match patients as infrastructure, coordination, and experience improve. Physical cross-match in multicentric swab. The decision to conduct specific test should be based on individual clinical circumstance. The physical cross-match, if undertaken, should be carried out at the transplant center where surgery will take place and follow standardized protocol. What should be promoted? Non-anonymous allocation versus anonymous allocation. Non-anonymous allocation means patients, donors, they are allowed to meet each other. They can exchange medical reports with each other. So non-anonymous allocation should be encouraged where culturally and ethically appropriate as it can foster trust, transparency, sense of shared altruism among participating donor and recipient pairs. Autonomy, privacy, preferences of all donor and recipient must be fully respected. Participation in non-anonymous arrangement should remain entirely voluntary, and no individual should be pressurized into identity disclosure. But so far, all centers in India are doing only non-anonymous allocation. That is, they can share medical reports with each other, and they can meet with each other before, during, and after transplant. Transparency for decision and for donors and recipients. SWAP program should provide clear, consistent, standardized information to both donors and recipients at every stage of swap process, including details of matching procedure, medical, logistical consideration, potential risk, available options, legal and ethical implications. All communication should be delivered in a culturally sensitive, understandable format, respecting each participant's autonomy, literacy, and emotional need. Then what should be preferred? Donor travel versus kidney transport. So far, in India, more than 100 cases of multicentric swap is done, and all have preferred donor travel. So participating transplant team should carefully assess most appropriate mode of exchange, donor travel versus kidney transport, on case by case basis, and decision of donor and recipient should be final. Donor travel is generally preferred as per Indian evidence. However, kidney transport may be considered for public private hospital swap with consent of payers. Donor travel possesses a significant personal, medical, and legal burden. Surgical or transplant capacity is centralized in one center. Institutional or recipient specific factor make organ shipment more appropriate. All decisions must be documented transparently, supported by informed consent, and guided by national regulations and best clinical practice. Noto Transport SOP for multicentric swap. Noto Transport SOP for organ transplant should be integrated with the National Swap Program also to ensure operational readiness, equity of access, and clinical viability in swap across diverse geographical area of the India. Then simultaneous versus sequential surgery. The gold standard is the simultaneous surgery. Donor nephrectomy must be performed simultaneously to prevent donor renage, while corresponding recipient surgery can be conducted simultaneously or sequentially. Sequential surgery should be undertaken in a carefully selected pairs by team with prior experience to minimize donor renage. All efforts should be done to minimize surgical interval and ensure recipients are transplanted before their donors give their kidney. Every precaution should be taken to avoid risk of donor renage. Then unequal outcome for payers. Transplant team should focus on clear counseling and informed consent, follow standardized transplant protocol for evaluation, comprehensive immunological assessment. The possibility of unpredictable complication and rejection up to 5 to 10% is possible despite all efforts. And this unequal outcome is mainly due to comorbid conditions in the patient. We can prevent unequal outcome due to donor related factor, but we cannot prevent unequal outcome because of patient related factors like comorbid conditions. This should be appropriately counseled and documented before transplant. Consent in the swap. All donors and recipient must be fully informed about risk, benefit, logistics with written consent obtained from all pairs in the native language. Social, cultural, and religious differences. By respecting and addressing diverse social, cultural, and religious factors, the transplant team should ensure that process is more patient-centric and comfortable for every pair involved in the process. Strict policies against financial compensation should be followed as per Organ Act. Donor should undergo mandatory psychological evaluation to prevent coercion as mandated in Form 4 for fitness of living donor kidney transplant. Then how we can manage financial differences between the pairs? especially when we do swab between public and private hospital. Conducting swab between only public hospital or only private hospital. The solution is simple, but this reduces the donor pool and quality of matching. So this cannot be the ideal solution. Kidney transport instead of donor travel. This is more practical solution. This ensure that donor from public hospital do not incur higher cost of surgery. Kidney transport enable program to function across both public and private hospital while mitigating financial barrier. Extra cost of donor travel should be shared by all payers. Establishment of government fund to support any cost which is needed for donor travel or kidney transport. So kidney travel over donor travel. Financial disparity between the payers in public and private hospitals should be addressed by prioritizing kidney travel. Noto transport SOP should be implemented for kidney travel, covering additional cost for donor travel if needed. This can be done with the help of government funds or common funds from all the participating transplant center. Then phase implementation and teamwork for national swab program. It should be implemented in a phase manner, starting from city-based program, state program. Then successful city-based program and state program can be merged in the national program. Then gender-related concerns. Ensure equitable access, resource allocation and support for all gender. Additionally, counseling and educational material should be tailored to address unique challenges faced by women, including societal pressure, health concerns, and familiar responsibility. More female healthcare professionals and patient ambassadors should be involved in process to create more inclusive and supportive environment for woman and girl child, both as a recipient and donor. Then transplant coordinator should receive a specialized training to effectively counsel and support peers and function as a one-stop solution for all problem. It could be medical, legal, social, and financial guidance. So SWAP is basically a logistic issue. A one-stop solution will help the patient to overcome this logistic problem. To summarize, legal, cost-effective national swab transplant program will increase living donor kidney transplant by 25 to 35%, and this will prevent commercial transplant. Ease of doing swab using NOTO's One Nation One portal for registration, allocation, and expediting legal permission will overcome the logistic issue. One Nation, One Document checklist as issued by the NOTO is very useful because all majority of the states have adopted the Organ Act and they should follow this document checklist as circulated by the NOTO under the provision of Transplant Human Organ Act. User-friendly software for allocation. We can do more complex matching with the software. Incentives for promoting multicentric swap. I will request Dr. Anil Kumar sir for issuing one additional letter for mandatory counseling about available options for renal replacement therapy, including swap for any patient who is getting registered for the deceased donor kidney transplant. With the help of this, we will increase transplant for incompatible pairs and also, most importantly, reduce waiting time for pairs who are already registered in the deceased donor waiting list. We can use online document submission, video interview of the pairs to expedite the legal permission. Donor first policy should be prioritized to decide over donor travel versus kidney transport. Living donor advocates and swap patient ambassadors will overcome the concerns of the patient. Organ Act reform is needed to permit other than near related donors in the swap, and reform is also needed to permit international swap from near related donors. Most importantly, government support matters to start the National Swab Transplant Program. In year 2025, in 6 months at Kidney Institute Ahmedabad, we have performed 50 swab transplant, and this has increased access to living donor kidney transplant by 25 to 30%. At the end of March, we have done another 10-way swab transplants, 10 patients and 10 donors. These pairs were from 7 different states of India, suggesting unity in diversity. Thank you for your attention.
Thank you so much, sir, for showing us today how intent and coordination can make this happen even across regions. The One Nation, One Swab program is not just a slogan, but it is a revolution in patient management. Thank you so much.
Thank you, madam.
Thank you, Professor Kutte. And definitely the SWAP program has a potential to not only increase the donation, but also to improve the outcomes of the transplant because the donors are well matched with the recipients. So outcomes are also likely to improve. So thank you so much. And so we have, so you, I will request just a formal vote of thanks from Dr. Kanika Stogi to specialist Noto. She is a specialist in pathology at Noto. So she'll be proposing a vote of thanks to everyone.
So before we conclude, I would like to express my heartfelt gratitude to the chairperson, Dr. Sunita Sharma, Director General of Health Services, for her invaluable support and guidance in making this national webinar a success. Her unwavering commitment to public health and towards advancing the cause of organ donation in India continues to inspire and empower professionals across the country. I extend my deepest gratitude to all the distinguished speakers who joined us today. Your expertise, insights, and passionate advocacy have made this session truly meaningful. I thank our director, sir, Dr. Anil Kumar, for his guidance and support all along. His dedication to the cause strengthens our collective response to transform lives, organ donation, and transplantation. I'm thankful to the entire team at Noto for their tireless efforts in making this webinar a grand success. And lastly, we sincerely thank all our audience for contributing to a session rich with knowledge and purpose. Let's carry today's learnings into tomorrow's practice. And let's ensure that no one waits in vain for an organ and no gift of life is ever wasted. Thank you.